Welcome to Moving Conversations, a podcast for movement professionals by movement professionals. If you coach, train, or teach movement, Pilates, or fitness, then this podcast is for you. With more than 60 years of experience in fitness and Pilates, your hosts, Brian Ritchie and Nora St. John, explore the science of human movement, diving deep into the facts, myths, and common misconceptions, hoping to spark thought and conversation about how we view fitness and movement. Now, let's jump into Moving Conversations. And welcome back to Moving Conversations. I'm Brian Ritchie. Joining me as always is Nora St. John. Good morning, Nora. How you doing?
Quite well, Brian. How about yourself?
Doing all right. One day at a time, moving forward all the time. Go ahead.
So I understand you have a new graduate?
Oh,
you're
yes,
the proud papa of a new high school graduate?
Yes. My oldest Jake, he graduated from high school last 2 weeks ago, week and a half ago. And yeah, time flies. It is almost, it's very, very frightening, actually. I just feel like we just blinked. And I don't know if you see this, but on Facebook all the time, it'll say memories from, and sure enough, 2-year-old memory, or 16-year-old memory of my 2-year-old playing in the park, doing like American Ninja Warrior, jumping from one thing to the next and everything at 2 years old. I was looking at that thinking, that feels like yesterday. That literally feels like we just took the video, and I'm like, oh, man, time does fly. It does.
It does fly. So
for those of you watching on our social media platforms, watching us live, or excuse me, not live, but on video on YouTube, you're going to see that we do have a special guest with us today. I'm going to let Nora get into that in just a second and do the official introduction. But before we do that, do us a favor, hit that like and subscribe button. We really appreciate it. Every single time you do, it helps us out. Share, repost, do whatever you can. We really appreciate it. If you want to get in touch with us, hit us up through our email account at movingconvos@gmail.com is the best way to get in touch with us. You can also DM us through social media. Instagram is Moving Convos. So with no further ado, take it away, Nora.
For those of you who, again, are not on video, I am very, very pleased to announce our guest for today is Beth Kaplanek. And I've known Beth for quite a while now. She is a Polestar educator. She is a nurse, or I'm not sure if an ex-nurse, or I haven't really been a nurse in a while as far as I know. And she has specialized for a long time in hip and knee replacements. She's written a fantastic book. She runs amazing courses, and wanted to bring her on to talk about hip replacements, because I know from, being out there in the world that a whole lot of instructors always have questions like, well, should I do this? Should I do that? It was 2 years ago. What are the deals? So we just want to bring Beth on to get some advice for all of y'all who are working with clients with hip replacements.
Yeah, I think a lot of our clients, or a lot of our students do work with people with hip replacements. And what we were talking about just before we hit the record button was things have changed. In the last 10 years, things have changed dramatically. I know in my practice, we've seen so many people, and the difference in technology as well as recovery has, gone up incredibly. So I'm really looking forward to today's discussion and to see what you've seen on your end compared to what we've seen. And hopefully our, listeners will get a lot out of this.
So Beth, did I miss anything particular that you want to say about yourself and what you do and who you are?
Well, first of all, I'm very happy to be here, to have this opportunity to chat with you guys and share this information that's near and dear to my heart. And they call hip replacements the operation of the century, as well as knee replacements. And it certainly is. But you asked, okay, here it is. It's near and dear to my heart because I have 2 hip replacements, and I think might even be one of the first certified instructors in the world, especially after 2000, that had a hip replacement. And it started really early on in my life due to a condition I had from a water skiing accident as a child. And I became an instructor after I had the hip replacement. 6 months after my hip replacement, I discovered Pilates. Like, wow, what is this? This is like this is like such an awesome form of movement. And I was looking because I was already teaching before my hip sculpting and personal training as a nurse, because I really enjoyed that. Plus my passion for myself. But I knew after I had my hip replacement, which was 2001, oh my God, I have to find something that's going to work, that's going to rebuild the house, so to speak, and I really,
Yeah.
it wasn't like there was literature out there for me to follow. It was like, okay, abduction, adduction, stand, sit, walk, go up, I went like, well, this doesn't work in my life. I want to get back on my jet ski. You know what I mean? you know,
Yeah.
I want to, I want to function at a higher capacity. And I was one of the, I guess, early on people who said, I may be disabled for this moment, but I'm a very abled person who wants to go back to full sports. And so I set out to figure out what I could do. And I found Pilates. And then that led me back to my doctor within 8 or 9 months. And he goes, "What are you doing? Because you look really good and your other hip's looking good. So by x-ray, so what are you doing?" And I explained to Dr. Jaffe, I'm doing Pilates. And I was afraid to tell him that I was doing Pilates, you understand? Because I was really at that. I had hip replacement posterior lateral, which we had a lot of restrictions in those days. So I was very conscious of, I always go onto the edge, and then back up. Then I'll back off. So he goes, no, he goes, I love this. Look,
Awesome.
I walked by this studio on Second Avenue because it was NYU where I had the surgery, and I see these people doing that stuff. And I was wanted to know what that was. He says, could I interest you in going a little further? So over the course of the year, he said, I want you to do more. I was just doing mat. And he says, could you learn more? Could I put you with a researcher and we do a little discussions on Pilates and how it could be good for this population? I said, I am in for it if you're in for it. And that's how I got started. And that's exactly how I got started.
That's amazing. So that's like personal and professional. So you had very strong motivations in both areas, right?
Yeah.
Like I got to fix this myself. And certainly 25 years ago, there was not a lot of again, we talked about this because Beth was also on Advancement Principles talking about this with me. And one of the things that we talked about at that time was hip replacements used to primarily be something that people got when they were very old.
Right.
And basically it was, the goal with it was just to get them back to basic function. And now people are having hip replacements much younger and they have much higher expectations about what they're going back to, full-time skiing, running, hiking, all the life activities they're interested in.
Exactly. Because then in essence, we are talking about two different populations. We're talking about a population that maybe broke their hip and they have to have a hip replacement. And then they're an older person where it just has to get done, but they're still very sedentary. That's one type of individual. And you have to base it on the individual needs of that person, right? And then there's the other person that could be anywhere today, 45 to 65, and they want to go back to full function. And they're not willing to live in that disabled spot where they cannot walk up and down stairs comfortably. They can't do their activities well. And there's depression and self-esteem issues and they feeling old, and that's not where they are today. And so the literature and the things we're going to talk about a little bit today are more related to getting that person back to full function. And certainly it works for all. Okay. But the harder was what I walked into is I didn't have a book to go by. I didn't have information to go by. And I was, not to get off target, but when I was going through the full program, I was less than a year post-op. Okay. So I was going through the full equipment program. So nobody wanted to work with me paired up to.
They were scared.
Right?
They were scared, I don't know how to deal with this.
Yeah, so I felt not only was I somebody that was unusual because I was in my 40s at the time, the end of my 40s when I went through the program, but still I was considered older because it was classical Pilates, and they didn't want to work with me because I had a joint replacement. They were scared. So, and I understood that. So that led me to having double passion to say, this is just beginning to change in this world. And where we have gone to becoming the operation of the century is really, that means there's about 1 million, there'll be about 2030, about 1 million hips done annually and much more for knee replacements.
Wow.
And most of those people are 45 to 65 now. That population has grown by 50%. So we are really, that's our clients, and we need the skills in order to work with them and not be uncomfortable, or we need to find a way to lessen the fear of working with somebody who's had surgery and know that they're going to be okay.
It is interesting that this is almost reverse ageism, in that a lot of times when you have someone who's much younger who has one of these things. My first one was a triathlete who actually had a double hip replacement, and actually not only a hip replacement, but double revision, because she had hepatitis C and was on prednisone for a long period of time. And by 40 years of age, she had a revision already on both sides, but she was a triathlete and a high level one. So she really wanted to push. But at that point, this was 20 years ago or so, the people we were seeing primarily were our 65-year-olds. And after the last revision, she said, yeah, my doctor said, oh, just do whatever you can, you know, and the PT was very much skewed for someone who was 65 to 85, stand up, sit down, you know, some of the more basic things that really for her was not going to cut it whatsoever. No. And now we're definitely seeing that they're treated that way. They're still treated as though they're much older than they are, but we're seeing people who are younger, who want to go hiking, who want to do more. So it's really almost that reverse ageism, like I said, that we're seeing that, okay, we can do more and we need to do more for these clients of ours.
Not just that, Brian. Also, we need to figure out how to maintain the lifelong hood of the prosthetic device. That has in its way historically had a timeline of no more than 20 years. And if you got 30, you're blessed, right? Yep. And it was based on the materials that were being used at the time would dictate that. But more so, if you could live a sedentary life and you do not do what you need to do to get back to full function and build the house, then we have a problem with not making sure that the muscular structure around it is supporting the device versus walking on the device, prosthetic device, okay? So you got to build the house and keep the muscles and everything strong in order to maintain the lifelong hood. So something that's 20 can get 30, and that most certainly is something that we need to take a look at or consider when working with people, you know, or people who have joint replacements need to consider that themselves. Actually, you got to do this. This is your job.
Yeah.
I do wonder how many physicians even think that way. And the reason I say that is I still hear people come to me and say, oh yeah, my doctor doesn't want me to have this done yet because, you know, it's only going to last 10 years. And I said, I don't know about that. I've got a number of people that are well into 20 plus years and they have no pain, no discomfort. They're strong as they've ever been, if not stronger. And that's sort of a surprise to them because they said, well, my doctor said it's only going to last me 10 years. And I said, well, maybe that's one person's opinion and that's one path. However, the other path is you can get stronger. You can build, as you say, build the house. You can get them much more functional and moving better. And it can last a whole lot longer.
Well, actually, I guess I'm an example of that. Mine is 26 years old. It's also a little bit, you know, you could have, which we probably could talk about the differences, but where it was 20 some years ago is we were reliant upon the materials that were used for joint replacements at the time. Now I was very blessed that I have a ceramic on ceramic. While that's like the ideal, and it was an experimental hip of Jaffe's at the end of a piece of research he was doing on that prosthetic device. They don't use a ceramic on ceramic bearing anymore. That means a ceramic liner, a ceramic cup that is the liner and the head. And I don't have a polyethylene liner. So now they come with a high cross-link polyethylene liner that is long lasting and would provide what I'm having a little trouble with this hip replacement is it's a little bit squeaky because I don't have that liner. So it just sounds like there's a knock going on, a squeak going on. And that's the ceramic on the ceramic, unfortunately. But that was what it was. And my asset is ceramic is very strong. And there's a really good chance that I'll have this joint replacement for my lifelong hood. if I'm lucky. If not, it is a age related situation in terms of the bearings. So yeah, there
So,
goes that.
so let me take this back a minute for our instructors. So one of the
Yes.
things that I know a lot of the instructors that I talked to, and I'm sure you too as well, since you've taught so many courses on this topic, like the primary questions they have, one of them is, what's the difference between an anterior and a posterior
Mm-hmm.
approach? And oftentimes posterior approaches are oftentimes longer ago. It seems like anterior is more common now, but they could do either. And I know that the precautions are different for both of those. So if you
Okay.
would just like outline that would be helpful, what that all means, because they're going to
Yes.
hear that and I want them to know what that means.
Exactly. So you're right, Nora. There are, historically, posterior and posterior lateral approach means from the side, around where the greater trochanter is, and up the glutes. Some a little more lateral, some a little more posterior, somewhere in between. Depends on surgeon preference and what they learned when they were schooling with the surgeon they were schooling. And so that approach, and it was historically a very large incision, and it was a window open to the joint capsule so they could get in there and really visualize it well. And they would take off certain muscles, in particular piriformis or some of the external rotators, to get in to view the capsule and do the joint replacement. So there's that. And that has, now we're going to come back to posterior and lateral. That's the way it was. And it came with a whole slew of precautions, which I will get into in just a minute, which we still should use. Then there is the anterior, or anterior lateralish, which is more to the front of the hip where the hip flexors are. And it's muscle sparing, and they part the way. There's no muscles that are cut, but they retract the psoas. They get in and they split between the tensor fascia lata and rectus femoris most of the time, and split it open to visualize the capsule, then go into the capsule and do the joint replacement. And that approach has less restrictions because there's more muscle sparing.
Got it.
Now, not to muddy the water, there are restrictions that I would say that are needed for both. And while there's many more for the posterior lateral, there are still some for the anterior. I think surgeons were very eager with the anterior and would say, you can do anything you want. But the reality is you really can't do anything you want because the body needs time for healing. And the timelines are 6 weeks to 1 week to 6 weeks, 6 weeks to 3 months, 3 months to 6 months, and 6 months and beyond. And we need to look at those categories, if not from the perspective of approach, for the perspective of healing tissues.
That's a good
Got
way
it?
to think about
Okay.
it. Yeah.
So regardless of the eagerness of the surgeon, because what I want to do now is come back to this posterior lateral that I was describing, that was big incision, that they retract and take certain muscles off. They tag them and then put them back. That is now changed. So now the posterior lateral is becoming so minimally invasive, and they're parting more and taking off less. And if they take something off, they're doing it in such a way that it's labeled and it's precisionally and meticulously sewn back on. And the capsule itself, which they didn't pay enough attention to in the earlier days, they meticulously put back the capsule, which is the synovial fluid membrane, as well as the ligaments that surround it, then the musculature, and they back out seamlessly. And because it's only 2 to 4 inch incision now, which used to be 10 inch, and the posterior laterals are beginning to look a lot like the anteriors. So for today, now that we're talking about current, these last couple of years, we have a 40 to 50% rate of anterior being used and 40 to 50% rate of posterior lateral being used as of now, today.
But totally different approaches than they used to have, right?
Yes.
Both of them pretty minimally invasive. Again, muscle sparing-ish or muscle returning-ish in either case.
Right.
And this is also why, like when I think about the old hip replacements I used to work with and the current ones, like I'd have a hip replacement tomorrow. They just are not as problematic
Amazing.
as they used to be at all. Clients
Amazing.
are up, they're back, they get their rehab done, they're back skiing, they're back dancing, they're back everything. It's really such a big difference.
Yeah, no, they still have to wait till after 3 months
Yeah.
to begin any kind of activities that they were doing. So our students of Pilates need to know a little bit more than that. So when somebody
Yes.
has a posterior lateral, just to put in the synopsis, and this is stuff that I explain in the course in detail,
Yeah.
they need to watch that first week to 6 weeks is a very key time to where they're not really with the average instructor, they're in physical therapy.
Yeah.
One other question would be like, so when does a Pilates instructor really to start to work with a client with a joint replacement? Generally not before 8 weeks, if not 3 months, generally. Okay.
Yeah.
An educated instructor can start much earlier on. Somebody who's a post-rehab specialist can start much earlier on, like I did with a lot of my clients. I start between 4 and 6 weeks. But that first 2 weeks, they're home for that first week. After the second week, they really begin more of an active physical therapy. Okay. And again, that's surgeon preference too. But today the surgeons I want you to heal for these first 2 weeks. And here's your 7 or 8 little exercises you're going to do. And you're going to, if you're posterior lateral, sit in a chair at 90 degrees of flexion. That's it. No internal, external rotation, just some basic abduction, adduction, and standing or lying supine, and do these simple 8 or 9 movements and get up every hour.
Okay.
And get up every hour. And then when they get to PT, then we start adding in specific movements that include a little more abduction, abduction, adduction, and quad sets and ankle pumps and things that they've been doing at home. And now they start adding a little bit of external, internal rotation based on the client and based on whether it's anterior or posterior.
Okay.
And then I would say after about the first 6 weeks, we can start adding in basic footwork. Okay? Basic footwork. And there's not a lot that first 6 weeks to 3 months, footwork, supine arms on a box. Okay. We want to be where we're giving a little bit more space for the hip just because it's healing, even in an anterior. Give them a little more space. Yeah, the biggest precaution that we have with anterior is that people start too early doing a supine leg lift, just picking the leg straight up. When they've had surgery with their hip flexors. That needs to be assisted with a TheraBand, right? So
or a strap or whatever. Something that keeps the weight down. Yeah.
Right. So for the first 4 weeks, no long lever supine leg lifts. The knee has to be bent to be picked up. So they don't put stress on the anterior aspect of the hip where that soft tissue has been disrupted from surgery and the incision needs to heal. Otherwise, they may end up with tendinitis.
So one of the things that I often think about with anybody who's had surgery, and this is surgery, is I always just in my mind think like 6 to 8 weeks is what most people say. Then the tissues will be relatively healed from whatever trauma has been put onto them, roughly. Just the initial phase. And then what I often say is like, you got to get the tissues healed if there's, tearing or pulling or whatever that. But then you also, my always feeling is but you do want to start moving those tissues once that has occurred, not before it, because you just cause inflammation, irritation, tendonitis, that kind of thing. But once that healing is kind of in place, then gentle, appropriate movement can help to let that healing create stresses, if you will, or fascial, gliding in the muscles in an appropriate way for those muscles, but not until they've healed. If they haven't healed yet, you just get gook. At least that's my experience. Yeah.
Exactly. That's why for the first 6 weeks, usually with the PT, right?
Yeah.
And then 6 to 8 weeks, you might start seeing them come back into the studio. And this is based on case by case scenario. If somebody's had previous joint replacements, they're eager to come back a little sooner. If they're not, they're a little more reluctant based on fear to really get involved until they feel that they have been released by their medical doctor to do so, or the physical therapist has released them. As long as they're going to someplace where the person knows what they're doing.
Right.
Because while the restrictions that we need to be really talking a little more of are those for posterior lateral, and maybe we should get back to that for just a minute. So that category 1 to 6 weeks is 90 degrees of flexion, nothing else. Okay, that's it. And then at 6 weeks to 3 months, we can increase that flexion by a little bit, maybe up to 100 degrees, just a little past sitting in a chair, and a little bit of internal external rotation. And there's a scale, but again, this is based on surgeon preference and current technology, minimal invasive. Maybe he doesn't want any of those that many precautions. But what we as instructors should follow is more precautions than maybe what the surgeon wants.
Yeah, more conservative.
Therefore, being more conservative is always better, right?
Yeah,
so if we know the joint capsule, that inner joint capsule I talked about, the synovial membrane and fluid that has to be rebuilt inside the body rebuilds it itself, and then all the ligaments around it that they have to part and move, all that tissue has to be sewn back and then have to get out, right? Through the muscles and then the skin. So the joint capsule and the initial stage of that joint capsule healing is 6 weeks. While surgery first 6 weeks is great in that the skin, the superficial layers of skin are healing and things, but deep healing, that joint capsule takes beginning at 6 weeks and ends at 3 months.
Okay.
That's why we want to be very careful with the 6 weeks to 3 month category
That's
of
great.
minimal movement, maximum benefit. All right. A little internal, external rotation, stay more in the sagittal plane, not so much in the transverse plane. Yes, you can work in the frontal plane. You can do abduction and adduction, sideline, assisted for sure, but on the reformer, if I were to just pop off a 6 week to 3 month program, it would be footwork and arms on a box, and maybe at 2 months, I would start to introduce a little bit of prone for a posterior lateral because it's high on a higher reformer, just a little bit because it's not an anterior, and things of that nature, setting on a box to do a lot of work, even just rolling back a little bit and rolling back up. Stomach massage, if you're going to do something like that, you do it on a box. It would never be done on the carriage. And that would be, you're setting back further in your feet. You're just doing gentle in and out. And that keeps the precautions. Side splits, I wouldn't enter into at least 3 months because it's not going to feel good on that joint capsule. So that's a no-no. And hip stretch and scooter and things of that nature should have a precaution for the first 3 months. So feet and straps, not really a problem. Actually, that would be gentle feet and straps after 6 to 8 weeks, not a problem at all. And
but it sounds like, let me just, so it sounds like with abduction and adduction, in the first phase, you're thinking about keeping it parallel.
Right.
Rather than doing some external internal rotation. Right. Okay, so just to clarify that little piece, so kind of stick with that. If you're doing abduction, adduction, relatively parallel, not so much internal, external yet?
No, if you're able to lay on your side at that point, you're just doing straight up and down, front, back, and circles, right? Working on basic abduction. And that would be lateral. Okay. Standing, wonderful. Standing, and even standing on a box at the end of the trapeze, doing hip extension, abduction, adduction, and circles, either standing side of the box, holding on the trapeze table, doing standing leg work is excellent.
No resistance or with resistance?
Well, I start with
first no resistance and then add like a light spring.
Then you can add, because we have the crossbar, you could add a yellow spring and very gentle work with a long loop on the bottom of the foot. It's very easy to do. It's also, the clients really like it. They're standing and standing work is so important. We need to start bearing weight. So at one point at the end of 2 months going to 3 months, I want them to start going into quadruped just to feel just weighting that joint. Okay.
Right.
Just basic quadruped and then extending one leg back in and out. Not necessarily on the reformer, just on the mat, on a high table. For the first 3 months, they should be on a high table, like the trapeze table. Then after that, start working down to the floor.
And then you're also talking a lot about doing things seated on a box, for example. So I assume that's because you don't want to be like, if you're sitting doing arm work, for example, on the reformer, and you're cross-legged or your legs are straight, you're going to be more than 90. If you've got that flexibility.
Yes, exactly.
So you want to be up so that you're really keeping that roughly that 90 degree or below situation.
Yeah. I really prefer the regular height, regular 14-inch reformer, or 18 if you're going to use a box, right?
Right.
And then there's the clinical height reformer, which you set on and you're already in a good spot, which is the best for
Right.
getting on and off for footwork.
Yeah.
But feet and straps is good. Bridging is good. I like bridging because the legs are elevated on the foot bar, and that gives more space. A low bridge can be sometimes problematic in the early stage so you put your feet up on a box if you're on the mat, on the trapeze table to do the bridging. The trapeze table is a wealth of things you can do on the trapeze table, even a little bit more than the reformer to some extent. And
well, you don't have the instability of the carriage, right? And you
Right.
can really isolate. I mean, you can isolate vectors. You can put a spring here to just,
Exactly.
activate that piece of extension or that piece of abduction. Yeah. So you've got a lot of more options in terms of controlling the angles and controlling the vectors.
Yes. And you can use, the ankle cuffs and thigh cuffs, which are really great.
Right.
And they're really wonderful, and they're a great asset on the trapeze table. And it's very easy to adapt many of the things that trapeze. Now, my book with the course has all those adaptations built into it. Yeah, so the instructors have to use their imagination about what we're talking about. But let's say you wanted to use an ankle cuff and do some assisted side leg work. And then I want to come back to the reformer for just a minute of why supine arms. Don't let me forget this. It's probably not an easy thing to do early on, and why.
Right. Because, you can't hold the legs at 90. A lot of people can't hold the legs at 90 degrees anyway. They can only hold them above 90 just to be there.
Exactly, which is why I do arms just sitting on a box. Things you would have historically done kneeling, do it on a box.
Right.
Right. Make it more basic. That's what you do in the beginning. It's not supine arms that we think is a beginning exercise.
Yeah, not for them.
And using the jump board for footwork is wonderful. It's because the whole foot is supported, and they can go in and out, do dorsiflexion and plantar flexion, and really feel the jump board under their foot more than even just the regular foot bar. It feels great. It's a wonderful way to do some footwork, and not jumping, just footwork.
Yeah.
And so, and it's also, there's a way to put your feet on the jump board and work supine arms and just spring the carriage up, and their legs are supported on the jump board, and they're just using the arms. So you can set it up that way too. A very basic early on, especially for some people, even for a deconditioned client, it's a good thing to do. So let's go to the trapeze table. What is a nice modified thing you can do on the trapeze table that is somebody who's really having trouble just picking the leg up in abduction? Is to use an ankle cuff. Take your breathing bar, bring it all the way down, and do a yellow from the center, short yellow. Have them lay on the side, put an ankle cuff, and just have the spring assist them and up and down to do assisted side kicks. Is a really nice thing to do, and it helps them find that mechanism of movement and proprioception.
And one of the things I like to say on that is a lot of people, a lot of instructors are not that familiar with, on the trapeze, taking that bar, right, that cross bar, and bringing it all the way kind of over the leg, so the angle is more direct. But they're so used to attaching it from the end.
Back. Yeah.
Right. And that's often not the angle that you want for this. You kind of want it more. You may not be quite directly over the ankle, because sometimes you don't get a lot of resistance that way, but closer to directly over the ankle. So that angle is pretty straight.
If you use a short yellow, you get good enough for this, and then it can be straight in line. And if you wanted to accent hip extension, if there's 3 hooks on your breathing bar, put it on the front hook, so they have to work harder to get that extension. And we know people need dorsiflexion and hip extension. Those are the 2 things that we lose over time, just as we mature in life, right? So the same thing with this population. We want to get them back to full walking, right? So a lot of work on their feet, a lot of footwork, on whether it's standing or lying. It needs to be done. Pay attention to the feet. Is what I'm saying. Pay attention to the hips, pay attention to the feet, pay attention to the knee, and pay attention to alignment. And
what's nice about using the foot bar, or excuse me, not the foot bar, but the jump board in that sense, is you can make it a little bit more how should I put this? You can give them more variety of their foot position. You can move that around a little bit because that's real life. We don't stay in the same place all the time. You can move one slightly external, one slightly straight ahead. You can put one slightly abducted, one a little closer to the midline. You can move things around a little bit to give them that variety of real life. And you can also do more ankle flexion, dorsiflexion, and really get them into, like I say, more of a reality-based type of program. Whereas I think the foot bar is a little bit more limiting in that sense.
Right. Well, who knows? Nothing comes in a vacuum. There's a lot of coexisting conditions that go along with hip replacements. Back issues, sciatica. As a matter of fact, I had a lot of sciatica in the beginning. So you're right, Brian, that's a really good point. And also think about the weight bearing that you feel a little bit more when your whole foot feels the jump board.
Yeah,
and
more natural.
And a little more natural. And you can have your heels way at the top of the jump board, and having them up higher is even better in the beginning stages. So there's a lot of use of the jump board that I think that we don't use enough of. Okay.
Yeah.
And I used it with my knee replacement too. It was much easier for me with the knee replacement. Now, later on, after 2 months, more to 3 months, then you start tower footwork. That's opposite for a knee replacement. For a knee replacement, you start tower footwork early from the beginning, but for a hip replacement, you do tower footwork, which in reverse. We're talking about where you're laying down on the trapeze.
And the head's away from the tower.
Away from the tower.
So you're not too tight.
And you've got it sprung up with the safety that you're using 2 long springs, not short springs. So you can maintain, because you can maintain the precautions, right? But the fact that you're using, I love tower footwork because it really puts pressure in your femur and drives the head of the femur down in the back pocket. So you get a really good excursion of the joint. And we're not often there. That's why I love a TheraBand for single leg circles.
That pulling in,
that pulling pressure down to really get the back of the socket really massaged. Motion is lotion, right? And we live more on the anterior portion of the hip. That's why people have a lot of tears in the labrum in the anterior port, because the head of the head likes to go too far up, and we want to keep it down and get that nice excursion.
Also, if you're thinking about getting the body used to a prosthesis, then using the full when it's appropriate, again after that like kind of 3-month mark, when it's appropriate to really start to get that full glide of the femoral head in the acetabulum, that's critical both for, I assume, keeping the prosthesis moving and gliding and stimulated, and also for really stimulating the whole muscular support of that. To your point, building the house. You have to build the house ultimately with the hip in all directions, in all dimensions, because that's how they're presumably going to use it if they're going to be active.
You're absolutely correct. Now think about the prehabilitation before surgery, how important that is to get that excursion on the back of the hip. So I want all of the students out there or Pilates instructors out there to really understand that getting that glide of the femoral head down in the back pocket of the hip is key in a general note. So whatever you can do in your general practice with all people to do that more often is good. And Pilates has that repertoire. And Pilates is fantastic segue from physical therapy to post-rehab and back to full fitness. It's the only discipline that I know out there that really gives you that beautiful, cohesive highway back and is akin to physical therapy.
Yeah, it is. I mean, I know Jonathan Hoffman, who was our Coraline creator, used fixed, foundation, and fun as kind of 3 categories of that. Fixed foundation is the physical therapist. They're doing manual work or they're doing things. Foundation is building that positive movement patterns, good myofascial balance around the joint, good joint mechanics. Like that's the foundation that then people can go off and do whatever they need to do. And Brian is a Pilates teacher, but he's also a personal trainer who works very much in that building a foundation mode. How do you get somebody really working in all planes and get themselves strong and balanced in those ways? And that's just, again, Pilates I think that's its strength for sure. I'm with you on that.
Okay. in terms of the range of motion guidelines for that, we're really talking about that first year of building the house. I want to make that point too. I gave you
Yes.
the categories of 1 to 6 weeks, 6 weeks to 3 months, 3 months to 6 months as you're slowly transitioning back to full function. Okay.
Mhm.
And the precautions are starting to be lessened, and you can do a little bit more work, and the flexion precautions are a little bit less, but with a posterior lateral, there'll always be some, and the body doesn't want to go beyond what it can. But I'd be remiss if I didn't mention one thing that's really a major contraindication. And let's put that out here now. Anything where you flex the hip, adduct it across the midline, and internally rotate it for a posterior lateral is a no-no.
So no
Because
soccer. Right? No playing soccer with your kids on a Sunday afternoon.
Yeah, because that's the way they get into the posterior laterals. They set you up that way. So you don't want to go 90 degrees of flexion, adduction, and internal rotation, because now we're really creating possible stress on those posterior lateral pieces. However, remember, we're in this point where things are changing to current way of doing a posterior lateral is so minimal invasive, and they're doing muscle sparing and sewing back everything seamlessly that there maybe that'll lessen. But that one piece is I want everybody to be very cautious of. And I can't think of a lot of exercises specifically that we do in Pilates except Z-sit.
Right.
A little bit fits into that. So you have to be a little cautious of Z-sit. Now, after the first year, but somebody's done their due diligence of regular working out, if not every day, doing something at least 3 times a week of Pilates and other modalities, their weight bearing and their balance work and so on and so forth, and their aerobics, then they can really go back to doing a lot of things that they miss doing and comfortably. And they don't even know they have a hip replacement if they've done it by that. If they've done all of that, especially currently, and they've done what they've had to do that first year to build that house back up, they're out for the races. They really are. And their body will tell them when to stop. Their body will. It'll say, no, you know what? That's a little bit too much pressure. But 90% of people are very happy with hip replacements.
Yeah.
And that number is getting better. Especially because of current techniques. We've got AI, computer technology, robotics, and they're doing a tremendous amount of mapping things out way ahead of time before they go, mapping everything out based on the anatomy of the individual to tailor make it work for them. And there's even 3D mapping, a 3D replacement parts coming down the way. It's kind of in trial right now where they'll 3D something for
3D printed specifically
3D printed, for that person's anatomy. I mean, I haven't seen that yet, but it's in the literature. It's in the literature. But there are hundreds and hundreds and hundreds and hundreds of parts, and they come in with this big box of parts from whatever company that surgeon does, and they size that person up. But they kind of know what they're doing if they've mapped it all out, which is what they do. And even if there's coexisting conditions, stenosis, spondylolisthesis, sciatica, knee problems, foot problems. So they size up the individual. They map. They take pictures from above the waist down now before surgery on a normal, so they can see how the alignment is set up, and then they'll map things out, computer generated. So a lot of great advances. A lot.
That has changed so radically. I'm sure Brian can speak to that too, because I think when I was first working with hip replacements, they had 3 or 4 sizes, or maybe 5 or 6 sizes, and a lot of my clients ended up with a little bit of a short hip or a little bit of a long leg or that kind of thing. All those things. One other thing I wanted to mention was what I found in several of my clients who have had hip replacements is some of them, maybe this is my opinion, but put off the replacement for a little too long and ended up in some really deeply compensated patterns, like super short on that one hip because they were really lifting from the QL, not from the hip flexors. And sometimes I found after hip replacement, like, yes, there's the hip replacement rehab, but I actually have to rehab the whole mechanics of that whole system because they've gotten so much in the habit of just not using it right.
Yeah, this is why early on, the exercise pelvic clock, just regular gentle pelvic clock,
Yeah.
how important that is to find that hip disassociation in the
Yep.
movements and learning how to teach to find hip disassociation and getting a little bit of mobility in the pelvis with the femur more fixed and being able to get those related parts moving in order to prevent a bit of what you're talking about. And even prehabilitation wise, we need to be teaching that so that when we come back, we have a segue into movements that our body has the muscle memory for, and we can go back that much faster. That's why prehabilitation is so important to early post-op rehabilitation. And the literature shows they do much better, faster
Hmm.
recovery.
So,
Okay.
so
I find that
Brian,
there's
I'm
a
sure
lot
that
of
is,
people
yeah.
that
Go on. Yeah.
no, what I find is that a lot of people oftentimes are afraid to use their hip, especially pre-surgery.
Mm-hmm.
They're afraid of the pain, obviously, but they're
Right.
also afraid of doing more damage. And the thing that I've noticed is the prehab is probably almost more important than the rehab
Mm-hmm.
component,
Mm-hmm.
because the
Mm-hmm.
stronger they go into the surgery, the faster and stronger they come out of it. I've had a number of people leave physical therapy so quickly because they're like, well, you've already kind of graduated. You've already established all of that you need to. So
Right.
I find that the prehab is of the utmost importance. And
Utmost.
you can do more than what people think you can.
Yeah. Yeah.
Yes, there's going to be some pain and discomfort, but you can find ranges of motion. You can move. I mean, think about the hip. We have so many different ranges of motion that we can move it in. So you can
Right.
often find a range of motion that doesn't have as much discomfort, doesn't have as much pain. Strengthen there first. See if you can
Right.
get a little bit more. And oftentimes they get comfortable doing that and they say, oh, I can do more than I thought I could.
Right. I have you're absolutely right, Brian. You're in my ballpark of thinking. If to get somebody ready for a joint replacement, and I have talking about a case study of an individual. I've taken her to two hip replacements and a knee replacement, and she does privates on a regular basis as well as group classes every single day.
Awesome.
And she did that up into surgery.
Mm-hmm.
And then I got her back within 4 weeks with me, and I had to hold her back. So no,
Mm-hmm.
I
Right.
don't want you going back. I don't want you going back. And I know you want to run into the group class, but here's what I need you to do. I need you to work with me a few more weeks because we got to let that joint capsule start having a little more space before you run and get on the reformer and try to keep up with the Joneses. I don't need you to do that right now, but
Yeah.
you're going to go there. So at 8 weeks, she was back full time in classes, group classes. So I mean, that was good for her, and she just walked. Yeah. Go
Now I
ahead,
have a
Brian.
question for you. This I've seen here in the Washington, D.C. area a lot, is a lot more physicians are no longer sending people to physical therapy afterwards. I'm getting a lot of people who are just being told, just walk, your body will figure it out. Just start walking. They get the in-home care. They get the immediate after, but 48
Right.
Wound
hours,
care.
72 hours afterwards,
Yep.
they're
Mhm.
really told, just walk, and so I've had a number of people come back to me because we've done the prehab and they say, well, the doctor's cleared me. And I said, you're a week out. You still have an open wound. I can't see you in a facility like this because I'm worried about infection and whatnot. But they say, oh no, I'm not allowed to do, they said no physical therapy for me. Are you seeing that too? Because I'm seeing that a lot more nowadays. So I'm starting to work with those clients earlier than I ever was before.
Right. You're right. You're right. And there was about 2 years ago a real impetus of that, where some doctors were mavericks and said, just go walk. You don't need anything else. I don't know. Regardless, all those soft tissues were traumatized.
I agree.
They need to find their way back. I mean, just walking in the sagittal plane is not going to where's my pelvic stabilizers? Where's my abductors? I'm not going to have a good gait, and there are some replacements that are done in a lateral, just a direct lateral, and they go through the medius and minimus and take the abductors two primaries off and then sew it back, which can create gait problems. So if that person has to have a timeline where they're not doing anything until those tissues are healed, and then they got to work really hard to build the stabilizers back and the abductors back. So yes, there is. And I think that we need to do a good job of telling people, you got to build the house. You want the lifelong hood of that joint replacement? Do you want to walk on the replacement, or do you want the muscles to help carry the replacement? Okay.
Yeah,
So,
absolutely.
so that would be my key line. Now I do a tremendous amount of everyday abduction and adduction work on my legs. I do sideline work on nausea, and it's best to do it without equipment. It's best to do it on your own, using your own body against resistance. Side kick series, just laying laterally.
Lift them up, move them around.
Yeah, all the way on your not even propped up on the arm, lengthened out, and find as
No,
much length out
I
of
did
that
this
leg and
way,
just
keep the spine
lengthen
straight.
up and lengthen down with 0 degrees of flexion of the hip, so that the abductors work harder, not the TFL. The TFL is an abductor also, but we want the glute medius and minimus and maximus to work more, right? And well, there are some components of the maximus that is an abductor in certain positions more than others, but having just general side leg work and front back circles up and down, we forget the lateral line.
Yeah,
And
always.
we do. And we need to work it more. People with joint replacements, especially hips, have to work it more, hips and knees. And they have to work harder to work on hip extensors and abductors in order to carry the house. So that's something I'm getting when we finish with our podcast today. I'm going to go work out for an hour, and that'll be in my routine. I always make sure that hip extensors, abductors, dorsiflexion, and thoracic expansion is in my routine on a regular basis. So more is better for people with joint replacements. We have to work a little harder. And it's schooling that we have to let them know. We have to educate our clients and let them know this is something you need to do on even at home. This is your home exercise program.
Yes.
This is something that you need to be doing. This is parcel. This is your lifelong hood of your prosthetic device, but for your ability to maintain pelvic stability and a good back. So let's just do it.
I think that's a really, I think that's just a critical piece. And again, to Brian's point, and I've certainly had this experience too, if you've got a medical professional telling you like you don't need anything you don't need any rehab, which happens all the time. Yeah, I was with a group of older ladies, and they're like, "Oh yes, well I want to do a reverse shoulder replacement because my doctor says I don't need any physical therapy after that." I'm like, "Oh Lord, whatever." But I think for you, what I loved what you said, Beth, and I would certainly tell my clients this is, this is not short term. Again, you want to keep this up because you want this prosthetic to last you as long as possible.
Yeah.
Because that's what's going to keep you moving, keep you healthy, increase your longevity, your resilience, and all the things you want to do. So I think that's a really important piece on that.
There's
something that I remind. Go ahead, please.
There's just one thing I would recommend that people with joint replacements not do too much of. Don't go out running on the road. Nobody needs to go back to running.
Repetitive impact.
The high impact is 4 times as much on their walking is great, but running or high impacts is not the best for joint replacements. It doesn't mean that we can't jump for a bone density. It just means that high impact running could wear out the liner a little sooner, and it create a revision for the future a little easier.
Well, you're talking about repetition, right? I mean, if I'm doing some jumping for osteoporosis, I'm probably not going to jump for 5 miles worth.
No, you don't need to.
Right, I'm just not going to.
No, but you need to have that. If you can do that weight bearing, even stand up, just jump a little bit. Just get that. We need to bear weight on those bones, because osteoporosis is also another issue. We go on another hour. You know that, Nora. Talking about the fact that for this population, they have to be careful with osteoporosis. They got to work harder to keep their bones strong. Yep. Because most of these devices are press fit, and the bone has to grow into this prosthetic device. So we need to be conscious of our bone density.
And particularly if they're women, they're at that period when their estrogen is probably going away now. So these are happening often concurrently, right?
Yes, for sure. Yes, they are. And that's a problem too, even in surgery.
Yep. Absolutely.
Something that I'd like to remind, something that I wanted to bring up is a lot of times what people don't realize, and I think people do want to shortchange their therapy. They don't want to go into it because they're either afraid of the pain or it hurts too much or whatever.
Right.
I like to remind people you get one shot. After surgery, you really get one shot at good physical therapy. Take it seriously. Don't shortchange yourself, because I have worked with too many people who shortchange their physical therapy, and it takes us 2, 3, 4 times as long a year, 2, 3 years later, because they've developed so many bad habits, so many inefficient movement patterns now that we have to erase. So I'm fighting against that. Whereas if they do really take their therapy seriously at the beginning, by the time they get to me, we can start going. We can really start strengthening and building their body back. Whereas if we have to just work with post-rehab for the next 6 or 8 months just to get them to where they should have been, it's really not in their best interest.
Right.
Yeah.
The literature shows that first year is key to how well that person will fare for the future. That's where the literature is. And that's where all the long-term studies are going. It used to be short time, 6 to 8 week studies, 6 to 8 week pre-op, prehabilitation and then how they, what happened to a year of prehabilitation? Why not? I should be getting ready for this. This is an elective surgery. You didn't just decide 6 weeks before. You need to keep moving. The more you move, motion is lotion. Now, I did PT, Brian, for my knee for 6 months when I had my knee replaced in 2022, because it needed that manual therapy. It needed much more therapy. Knees we're not discussing today, but hips, you need less of that, but you still have numbness down the side of your leg. You had an anterior. You still need myofascial release work. You still need deep tissue. You still need all of those things, not just movement. So we need to be working as a team. We need the physical therapist, we need the instructor, and we need the massage therapist or the myofascial release person. And if you can do those 3 things, you're going to do really well, like really well.
I want to just throw in here that more than once, and I know Brian and I have talked about this before, and I'm sure you had that experience too, Beth. Prehabilitation, I've had clients put off a hip replacement for years. Just from getting the strength that they didn't have, so they're they think they need a hip replacement. We just do some basic gait work and strengthen everything up. And they're like, oh, my hip doesn't hurt much anymore. I'm like, well, good. Then wait until it causes you trouble again. If it does, because if you, again, what you can do with muscles can sometimes really allow clients to be functional a lot longer before the hip replacement, which is also another useful thing about prehab.
You essentially put them back in a good alignment and congruency for a while. And they're not using as many compensatory strategies to get through that. And maybe that's all they really need. And maybe in many cases, that's what people really needed. I had slipped capital femoral epiphysis from a water skiing accident as a child.
Yeah, yours was not going to change with exercise.
No, that was not going to change. But the first hip replacement was 2001. The second was 2016.
Right.
So I bought years.
You had the same injury on both?
Yes, it was a water skiing accident. It was a slip for both hips for the same. It was a water skiing accident at 12, and the growth plate on the head of the femur slipped on both of my head. But the right was more severe than the left. So it had longer time before it became fatal, but it was still there. And nonetheless, I bought a lot of years. I bought a lot of time.
Yeah.
I bought a lot of time.
Years. Yeah.
Doing Pilates. That whole time I was doing Pilates.
Fantastic.
Yeah.
All right, Brian, take us home.
All right.
Well, there's a lot of information in here. Thank you so much for that.
A whole lot of information. Thank you so much for joining us. Wow. Let me ask you this. Would you share with our listeners your social media, how they can get in touch with you if they want more information about you and your program? Where should they reach out? Website? How would you like them to reach out to you?
I do have a website. It's bethkaplanek.com, www.bethkaplanek.com. And my email is my name, beth@bethkaplanek.com. And I do have an online asynchronous course called the Pilates Teacher's Perspective of Lower Extremity Pathologies and Joint Replacements, which includes a PDF of my book, as well as a complete 200-page manual for the course with everything, with probably hundreds of exercises that have been modified or mat work to do with people with knee and hip pathologies and joint replacements. And it's a wealth of information, and I highly recommend it. It's 16 CEC credits. And it's noted on my website, but also I think you're going to put it up on the podcast.
Yep, we're going to put it in the show notes. Absolutely.
Yep.
And Polestar has it under their continued education. Polestar Pilates has it under the continued education of how to access that course and the manuals and the book. And I will do a private Zoom with anybody who finishes the course. If they need a private Zoom, we just sit and chat and talk about things that they have questions about. And they have a lot. It's a lot to learn, but it's also a wealth of information that will really get them going and working comfortable with individuals with hip and knee pathologies and joint replacements, to where it's not a disaster. It's going to happen. You've got 2 to 3 people a week sometimes in your classes with these issues. And let's figure out how to make it easier on them and easier on yourselves, mainly as an instructor, so you feel really comfortable within your own skin and don't have that fear of working with individuals with certain disabilities. And I just don't know what to do. What do I do with sciatica? What do I do with patellofemoral syndrome? What do I do when somebody has iliopsoas tendonitis? What do I do? So this course does go through all of that.
Fantastic. Awesome. Well, thank you very, very much.
You're
and
welcome.
Thank you for
Thank
listening.
you.
We really appreciate every one of you listening. Do us a favor again, hit that like and subscribe button. We really appreciate it. Post, repost. We love it. And it really helps our algorithm. So thank you very much. movingconvos@gmail.com is the best way to get in touch with us. Check us out on Instagram, Moving Convos, as well as under my name, Brian Ritchie, on YouTube is the best way you can sort of see us in color instead of just the audio version. And so for Beth and Nora St. John, I'm Brian Ritchie. We'll see you next week.
Thanks, guys.
Thank you.